Thanks, Dr. Krishna Prasad. So our eminent speakers have told about what are the inter-segment complications can be there, which can make the patient unhappy. So I am just be touching what can be the retinal pathologies are there. Any retinal pathology can make the patient unhappy, but what are the retinal pathologies which can cause it? So the most important, like, it can be subnormal vision after a cataract surgery, which can be a non-improvement in the vision. That means after the cataract surgery, patient doesn't have any improvement in the vision, or initially he had a better improvement, then after some days there was a again decrease in the vision. Or it can be because of recurrent floaters, like multiple floaters like thing or flashes also might make the patient unhappy. So there are like various conditions which can cause the retinal conditions. Let me come to the common conditions. So the patient underwent a very nice cataract surgery, 6 for the vision. Then after 3 to 4 weeks, he came and says, I am not able to see clearly. My reading vision has becoming an issue. And when we see clinically, everything looks all right. IOL is in position and all. When you see the fundus, we can see there is something called a yellow dot sign sometimes, or slightly the FR reflex is dull. And when we do the OCT, we can able to see the presence of large cystic spaces and a neurosensory detachment. So this is commonly we see called cystoid macular edema. And most commonly we see it around 4 to 6 weeks after the cataract surgery. And if the patient has any intraoperative complications like PC rent or any other features, the chances of having this cystoid macular edema is common. And if the patient has previous history of uveitis or diabetes, the incidence of cystoid macular edema increases. So for these conditions, usually we prefer they resolve by itself. It will take at least 3 to 4 months to decrease. So what we do nowadays, we give we can give NSAIDs, Nepafenac or bromfenac eye drops, or we prefer to give steroids. Usually we prefer to give periocular steroids in that, like posterior subtenons or transeptal kinocort injections, or if it is not resolving till then we can go for the Ozurdex injection also, or we can go for the anti-VEGF injection also in certain conditions. So this is the one of the patient where after giving the kinocort injection, after by 1 month the cystoid macular edema is nicely decreased and the patient is happy. The other most important condition what we see nowadays is diabetes with cataract. So most of the patient will be having some type of diabetes and all. So two things can happen. The patient can have a diabetic macular edema before a cataract surgery, and the patient may have a large cataract, very mature cataract, and where we are not able to see. So it is associated with increased risk of worsening of the previous edema, and one study has shown that at least 22% of the patient can develop macular edema. So this is the one patient who had a mature cataract, and after doing a cataract surgery, we are seeing a large succinate retinopathy and having a large cystoid macular edema picture. So UK diabetic retinopathy study has shown, like after the cataract surgery, if the patient has severe NPDR and all, there is a high chance of developing diabetic macular edema in 3 to 6 months. Even if the patient has moderate or mild also, there is a high chance, but most commonly by 3 to 6 months, the diabetic macular edema will become clinically significant. The another study also says the same thing. There is a statistically significant increase in the macular edema after the cataract surgery. So that becomes important to analyze whether the cataract, diabetic macular edema or any diabetic changes are there or not in the patient. This is the one patient where patient has slightly extrafoveal macular edema before the cataract surgery, and when it comes after 3 weeks, you can able to see the macular edema has increased. So this patient required anti-VEGF injections, and after 2 or 3 injections, the vision became better. And another thing what we can miss sometimes when the cataract is more is the PDR with traction. So it may be very difficult to see certain times, and when we may miss this traction and neovascularization in the eyes with a cataract surgery. So it becomes important to see the peripheral retina also. Some patients may have the vein occlusion where there will be a thinning of the retina, and it may be missed because the retina becomes very, all the features of hemorrhage and all would have been decreased, and you may not able to identify this condition. So in these preoperative OCT becomes most important. It's ideal to do all the patients undergo preoperative OCT so that if any leftover or missed pathology can be found out. So this is another case where you can able to see there is a presence of tributary vein occlusion, or it's a old occlusion where clinically you may not able to identify it. But once after doing the cataract surgery, when the patient was not happy with his vision, and when we did a FA and all, we can able to see there's a presence of aneurysms, collaterals, and there was a thinning. Next, coming to the ERMs. So ERM can be there preoperatively or postoperatively, and many studies have shown the ERM per se may not increase because of the cataract surgery, but if the patient has ERM, there is high chance of having inflammation and macular edema having ERM. So it's better to look for the OCT and see how is the ERM is there before taking up the further cataract surgery. Here is one of the case where you can able to see there was a ERM with mild thickening, and after the cataract surgery there was an increase in the macular edema, this condition. So this study also says the same thing, where they have seen there is an increase in the macular edema than the ERM which is not progressing. Other important condition which may miss, because clinically it may be difficult to identify, where there will be like a slight enhanced red reflex which will be there, and that condition is vitreomacular traction. So clinically it may become difficult. So there becomes the importance of examining the near vision also. Usually in the case of any macular pathologies, the near vision is affected more compared to the distance vision. So even sometimes the patient may have macular hole also. The other thing which can happen is when the patient has VMT, and after doing a cataract surgery, the certain times the VMT can progress, and this VMT progression can lead into the macular hole. So the surgery went all right, everything, but the patient says his vision is blurred. So it's most important it becomes for us to see preoperatively how is the VMT, how is the vitreous adhesion and all. Another most important condition in the old age is AMD. It can be wet AMD or dry AMD. So OCT becomes important preoperatively to see whether any AMD features are there or not. So this is the condition of a dry AMD, geographic atrophy, and the vision loss may be because of that. So you have to look for the patient how he is seeing also. In the patient of wet AMD and dry AMD, their central vision is lost, but their peripheral vision will be good. So they are not able to identify who is the person who is coming. They were able to identify some person is coming. So look, when the patient is coming inside the OPD, look for his gait and look his vision how he is coming. That may give you an idea whether he has anterior segment pathology or a posterior segment pathology. So many studies have shown that whether the ARMD increases after the cataract surgery. Per se, as the age increases, the ARMD can increase, but many studies have shown that cataract surgery per se is not going to have an effect on the ARMD changes. So other very rare condition but very easily missed condition is parafoveal telangiectasias, where there will be some amount of early stage, there will be perifoveal graying and all, which can be missed very easily because it's a very not very rare but very underdiagnosed condition nowadays, because it's not clinically not significantly seen, but yes, OCT will help you to look onto this. The other most commonly we see is the chronic CSR, where the patient in the early stage, young age, the patient would have been having a CSR and all which has been resolved, but there is now a chronic CSR DRP like picture. And this patient, when they develop cataract, it may be missed because he may not give this history. He may not give this history of having this previous condition. So make sure and do an OCT once and to see whether there is any picture of foveal thinning is there or not. This is another picture showing you having the chronic CSR. If the patient is myopic and all, in a high myopia patient, sometimes there can be a myopic schisis or macular schisis. Make sure you look into that by doing an OCT. And very easily missed out condition is solar retinopathy, because clinically it looks almost right. It doesn't make difference, but OCT will show you the small lesion of ISOH junction disruption which can be seen here clinically. And other condition also most important becomes is taking the history of the patients. So some patient may be having the joint pains and all in the old age, and they may be on the HCQ tablets and all, or they may have some on other long-standing medications and all, like for example HCQ. So they may be taking since many years, and they may not reveal the history unless you ask them. So it becomes important for them to ask, are they taking any other medications and all, because HCQ can cause long-standing foveal changes. And OCT you can able to see here something called as flying saucer sign, where there is a thinning of the ISOH junction and all. Other common conditions which is usually can be seen if the young patient comes with a cataract around 35 to 40 years of age, which can be a complicated cataract, make sure to rule out any dystrophies are there or not in their eyes. Like in this RP patient has a typical cystoid macular edema, and the patient have central PSC also. Sometimes it may be missed because the patient may not give any history. The other most common condition which can be missed is the optic nerve pathologies, especially the ischemic maculopathy, ischemic optic neuropathies, where the NIN and all, they will be having initially, there will be a disc edema, but in the later stage, they will be having only a temporal pallor of the disc. And this is sometimes easily misdiagnosed or undiagnosed because we are not looking onto that. So make sure you look into that. If you have any doubt, get a visual fields done. So next, coming into the floaters. So many patients will come, the surgery, everything is good, but I am seeing something is moving in front of my eyes. Web-like thing is moving, or a mosquito is moving inside our eyes. So there can be many conditions, and we have seen after the cataract surgery, the PVD induction is more common. So this PVD can become complicated, or maybe a normal PVD also can cause the floaters. So reassure them, have the peripheral retinal examination, because up to the complete PVD occurs, there is a high chance of retinal breaks and all. Do the regular examination till 1 month to see any retinal tears happens or not, and reassure. If it is not decreased, then we have AIOC vitreolysis, or the patient is very much complaining, then we can go for vitrectomy also. Recurrent uveitis. If the lens is in sulcus, or the patient has pseudoexfoliation or any pigment dispersion syndrome, this can be the most common condition where the patient comes with recurrent redness. Even the vision is good, but he is not happy. So we have seen many patients having this recurrent redness if the patient has any complicated surgery or this thing. And also when there is a recurrent redness, you should also keep in mind of post-op endophthalmitis. The patient may, once you stop the steroids, the patient may have recurrent redness, pain, slight decrease in vision and all. So just keep in mind of post-op endo. Here you can able to see some whitish pigmentation and all which is there, which can be confused with, can be a PCO. But you should look for the how is the pigments and all, because if you do a YAG cap, the end of will further complicated. This is another case which will show the fungal end of growth which is there. The patient vision is 20/20, 6/12 like that, but he having this end of, and when the patient was on long-stand steroids. So, but even then afterwards we went inside, we did the, we cleared it up, and we did the cryo also on that area, so that because we, most of the time they say we have to explant IOL in a fungal this thing. But we tried doing the cryo and we didn't remove the IOL. Luckily, the patient recovered. Sometimes, yes, there is if there is a PC rent and all, some amount of cortex may go, some amount of the nucleus may go. And most of the time, they resolve by 1 or 2 months, giving a long-standing steroids. But sometimes, if the small nucleus goes and sits in the pars plana, it may not resolve and may cause recurrent redness and recurrent inflammation. So, proper history and previous treatment, whatever his patient is taking, it becomes very important. Complete evaluation, including the RAPD, becomes important in the condition. Preoperative OCT for all the patients help to detect any retinal problems to the certain extent. And if the mature cataract is there, better to do ultrasound B scan to rule out any retinal detachments or any other features which can be seen. And control of the diabetes and control of diabetic macular edema becomes very much important before doing a cataract surgery. Thank you.
Thank you so much, Sharat, for a